Record. There it is. It's what I was waiting for. Our topic for today is little known adverse effects of psychiatric medications. So we're going to talk just kind of briefly about some more common concerning adverse effects, but we're really going to focus on a handful of adverse effects with our mental health medications that may still be problematic for the patients. So there are three objectives that I hope to accomplish in our short time this morning. One is to list common and uncommon adverse effects of psychiatric medications. I'm going to focus on two classes of medicine just for the sake of time. So antidepressants and antipsychotics. We're going to identify which of the side effects are most likely to have patients stop taking their medicines. So ones that maybe we need to prioritize. And then we're going to look at a couple options that we could potentially put in place to help patients help manage these. There was a lot of help in that statement there. So I wanted to start first with the definition of adverse effects. So the whole focus today is on adverse effects. The first definition I found was in a very formal article, and I was taken a bit aback by the definition. So it said it's an appreciably harmful or unpleasant reaction resulting from an intervention related to the use of a medicinal product, which predicts hazard from future administration and warrants prevention or specific treatment or alteration of the dosage regimen or withdrawal of the product. And I was like, wow, that really sounds to me like adverse effects are absolutely always bad. And it means that we got to make massive changes to the regimen. So I was like, is that what everybody thinks of adverse effects? Because that wasn't necessarily the definition I would have given. So I found two other definitions. So one is an unintended harmful event attributed to the use of medicines. So again, really kind of having more of that, this is usually a bad thing. And the last was an undesirable or harmful effect. So I guess we couldn't get away from that completely, but really looking at, these are things that we aren't using the medicines for usually. Sometimes we can align that nicely, but for the most part, these are things that we're not intending to have happen and that could be really problematic for the patient. And it can happen with absolutely any medicine. It also happens with placebo, especially in some of the psychiatric illness trials. So recognizing we're going to focus on the psychotropic medications, it's pretty prevalent across the United States. It's estimated that 1 in 6 adults takes a psychotropic medication at some point. So that is relatively significant. That would suggest, based on our numbers, that between 4 and 5 of us gathered here would be on a psychotropic medication. In terms of classes, excuse me. So which are the most common? So if it's 1 in 6 and they could be on anything, which are the ones that we see most frequently? I was only able to find data from 2019. That was the most recent results that were posted. Antidepressants by far were the most common. Our serotonin reuptake inhibitors, which we're going to look at a list of them in just a second, really were the outright winners. Almost 50 million prescriptions were filled in the year of 2019 for sertraline, and just under 40 million were filled for Lexapro or escitalopram. So that really was the most common. It was followed by gabapentin, which is often used for pain. Some of our benzodiazepines, which can be used for anxiety. So Ativan or lorazepam and Xanax or alprazolam were the two most common. And then our stimulant medications, so Adderall, Ritalin, and a whole bunch of their formulations. Antipsychotics were the next group, but even though they fell kind of 5th in line of the most common, we were still using more than 20 million prescriptions of the quetiapine a year. So we're really going to focus on those two classes, as I would expect that you see quite a bit of use of those two classes of medicines. So D comes before P, so we're going to do antidepressants first. and they were the most common. So the SSRIs are selective serotonin reuptake inhibitors. So we have antidepressants as a big umbrella topic. The SSRIs are one class of antidepressants, kind of like if you think of fruit, there's a whole bunch of different types of fruit. So this would be like the apples. So these are the medicines that we're focused on. So Celexa, citalopram, Lexapro, or escitalopram, Prozac, fluoxetine, Paxil, paroxetine, and Zoloft sertraline. So those are really the ones that we're most focused on here. Patients tend, they are prescribed. Actually, it was estimated that 1 in 5 Americans at one point were taking an antidepressant. That changes over time, but for all of the individuals, so all of those 40 or 50 million prescriptions that are being filled, patients tend to be adherent. They tend to keep taking their medicine only between 40 and 70% of the time. That means between 30 and 60% of the time, they're not taking the medicine. Now, they stop taking the medicine for quite a few different reasons. For the depression, things that may get in the way are the severity of their illness, whether or not they can see a connection between improvement and the taking of the medicine. Substance use often plays a role in whether or not patients are going to continue taking their medicine. Other conditions, if they have stigma or they don't believe that the medication is going to help, so some of their own personal beliefs, as well as their socioeconomic status. So sometimes these could be expensive. Most of these are relatively inexpensive, but there may be situations where even an inexpensive medication really requires some thought about whether or not it's worth it to get this. And medication side effects are one of the reasons that individuals stop taking their meds. Lots of different factors. I'm just going to focus on the drug ones for now. So why would they stop taking their medicine? Well, in the short term, there are some side effects that patients experience that make them stop taking their medicine. So this is the first couple months when someone just starts taking this medicine. It makes them nauseous. All of these medications can definitely cause nausea. It can cause a headache. In some cases, it makes patients really drowsy, or they just feel fatigued, like they don't have a lot of energy for the first little bit. I would say fluoxetine, there are some patients that say that one's a little more activating, but there are still some individuals who get drowsy from that. And then anxiety. So we start you on a medicine, maybe for depression, maybe for anxiety, and it makes you drowsy, it makes you anxious, it gives you a headache, and you feel nauseous. It's probably going to do that for a week or two. Not a surprise. Why would I do that intentionally to myself when maybe I wasn't feeling great before for weeks on end, when I have to take this for a month or two before I see any type of benefit? So that really not a surprise. And those are relatively common. We see them in more than a third of patients who take it. And for the anxiety, we can see it up to 50% of those patients. Longer term, so those patients who are able to stay on their medicine for a longer period of time, they stop taking their medicine because of a couple different reasons. Sexual dysfunction being one. This is something that is relatively well known about the antidepressants. And weight gain is the other one. So weight gain isn't one that's commonly associated with the antidepressants. So that's the one I'm going to focus on today. So there has been quite a few questions that have been raised about how often this happens. So I went to each of the drugs information sites to try to find out how often do we see this. Well, we see information that goes in both directions, unfortunately. So because patients feel nauseous, they may be vomiting, they may have diarrhea when they first start it. It is common to see some weight loss initially, that they really don't want to eat anything because they don't feel like eating anything. That tends to be short term, so within the first 3 months of therapy. Once patients are on it for a longer period of time, we can see some weight gain. So the numbers look small, so only 1%. So that would be 1 out of 100 people are gaining weight. and the increase in appetite, okay, maybe up to 4%, but we really weren't going after this. We weren't looking at, does this actually cause weight gain? It was just something that somebody happened to mention in a clinical trial. So let's take a peek at the data. What does that say? Does that say this isn't a problem? Because people are stopping their medicine because they believe it makes them gain weight. So chances are there's something there. So this was a study that was done open label. So everybody knew what they were on. They followed the patients for 12 weeks. So still in that short-term time frame, they were put on Prozac or fluoxetine, and there were quite a few people. So over 800 patients were in there. They were looking at if they responded, they then were switched. They could either stay on the fluoxetine or they were given a placebo pill, but they didn't know which one that they were given. That one was double-blinded. And then they were followed either for another 14 weeks, for 38 weeks, or 50 weeks, because they wanted to see what happened to weight over time. So when they first started, when they were split either to fluoxetine or to placebo, they were about 73 kilograms. So that was where we started. The change in weight for those who were on the Prozac, the fluoxetine, we saw increases if they were at, I lost my little, well, I guess you can't see my mouse anyways. If they were on it for an additional 14 weeks, they gained 1.1 kilograms. So that's about 2 pounds. So a couple pounds in about 3 months might start to make a difference in the way your clothes feel. Those that stayed on it for 38 weeks gained about 2.2 kilograms. So they gained about 5 pounds. So probably starting to notice a difference. And those that stayed on it for almost a year, the 50 weeks, gained over 3 kilograms. So that's, you know, about 6.5, almost 7 pounds. So maybe as it seems small, but think about what that may feel like. An individual may feel different. It's almost 10%. You know, if you're 70 kilograms and we're gaining an additional 3, it's not looking like, hey, that's a whole bunch of weight gain. It's not reaching that threshold to where somebody would say that's important, but maybe I feel that's making a huge difference in the way that I move around, in the way that I feel, the way that my clothes fit. That threshold where they say it makes a difference is usually 7%, a 7 to 10% change from baseline. If we look at that, almost 5% of the patients who took it for 14 weeks met that threshold. 10% met it at the 38-week mark, and 13% met it at the 50-week mark. So there was definitely a group of patients that was gaining a significant amount of weight. One of the, I guess, confounding factors, one of the problems that we ran into in looking at this, yes, they're gaining weight. When they pooled the data and looked more long-term, okay, this looks like it's something that takes some time, they found that most, so these were the patients that were on the antidepressant, those that were on a placebo, and then they compared weight gain between them for taking the medicine for more than 12 weeks. There was only Paxil showed a difference compared to placebo. So it suggested that maybe they're gaining weight because their depression symptoms are improving. And that may actually show maybe they lost weight because they were depressed or anxious, and them gaining weight isn't necessarily a bad thing, that they're getting more to a normal weight range where they're supposed to be. Possibly, but as a reminder, it's one of the reasons those patients are starting to stop their medicine long term. So even though we don't see a difference in this table down here compared to placebo for most of ours, so Prozac's at the bottom, sertraline is the third one up from the bottom, that's our Zoloft. Even though it doesn't differ from the bar for the placebo pill, it is a concern. They are gaining weight compared to baseline. So that's something we want to be mindful of for the patients. If they say that they're gaining weight, to say, hey, the medicine doesn't really do that, well, that may not necessarily be the case. We don't have enough information to say it's definitely to blame, but there is something going on there. Their weight does tend to change over time, more so than if they weren't on these medicines. So weight, something we want to think about, something that the patients may bring up. There's a couple other factors I just wanted to highlight that the patients probably aren't going to bring up that we don't talk about very often. For your patients who may need to take a pain medicine, something like Advil all of the time, if they're also on an antidepressant, that increases their risk for bleeds. And that is one of the main concerns that we see with antidepressants. For patients who have taken antidepressants for a long time, they're at increased risk for fractures, for breaking a bone. And it increases the longer, the risk increases from almost 3% to over 13% the longer they're on the medicine. We're not exactly sure why that happens, but something that we want to be mindful of. They're not going to say, I'm stopping my medicine because I might break a bone. But if they start fracturing things, especially early on, that could be cause for concern. The last two items are low sodium levels, hyponatremia. So this could make a patient be unsteady. It might eventually lead to seizures. I highlight this one because a lot of our medicines can do this. And some of the conditions that they have, especially psychosis, can cause them sometimes to drink a lot of water and lower their sodium. If they're also on an antidepressant, that really increases that risk up a little bit higher. So something I want you to be mindful, if the patient seems like maybe something's going on, it wouldn't be super obvious, but something we want to be mindful of. And then cardiac arrhythmias, so heart arrhythmias. And this also happens a lot with our antipsychotics. That's a common adverse effect with our antipsychotics, but this adds to that risk. And unfortunately, there are some patients who develop fatal arrhythmias. So it's important that we make sure that we're following up routinely. What's going on with you with your medicines? Are you noticing anything? So opening that door for them to provide whatever information they're, whatever things they're experiencing is super, super important. That collaboration, we get those results, we need to make some decisions. There's no clear-cut intervention to say, hey, this is what we're going to do. With the weight gain, we can try, increasing physical activity or changing diet, or maybe we need to make some more adjustments, but we'll need some additional information there. So those are uncommon ones with our antidepressants. For our antipsychotics, I'm going to focus on one we talked about for antidepressants. So many of our antipsychotics, the adherence rates are between 40 and 76%. So maybe less, about half of our patients are probably consistently taking their medicines. Our movement disorders should not be a surprise. They feel restless, they are stiff, they have like those severe rigid muscle contractions, maybe they develop a tremor. All of those would be relatively common and often can be stigmatizing. They feel uncomfortable. People may look at me differently. I don't want to keep taking my medicine. Weight gain tends to be a common one. So maybe not always thought of with antidepressants, but it is something we are often looking at with antipsychotics. But one of the other main reasons they're stopping their antipsychotics is sexual dysfunction. So something that we would commonly think about with antidepressants can happen a lot with antipsychotics. So between 1/2 and 3/4 of the patients that are on antipsychotics report sexual dysfunction. They're probably not telling a whole lot of people about it, but they still have it. So if they're asked about it, the answer is yes. It happens in 3 different buckets. So they lose interest in any type of sexual activity. They have issues with arousal, both males and females, or they have dysfunction related to orgasm. They're unable to obtain orgasm, or it has a diminished intensity compared to what it had before they were on medicine. The way that the medicines work probably causes this. Its actions on dopamine and serotonin can interfere with all of this. What can we do about it? Well, ideally, we'd like them not to stop their medicine. In some cases, we might be able to drop the dose. In other cases, we might be able to add something to it. So if we have a patient who has issues with arousal, we have medicines that can be used for erectile dysfunction that may be beneficial. Sometimes they are, sometimes they're not. We really need some information from the patient to understand what's going on with them to give them the best recommendation. And I say that because I had a patient when I was a student, and he had erectile dysfunction, and the traditional, we had tried Viagra in him and it didn't work. but he got sick and he used Sudafed because he was all congested, and that was beneficial for him. So instead of it being one mechanism that we were thinking of, actually that stimulant was really effective to be able to treat him. So he used that in place of Viagra moving forward. And then maybe we can switch. So maybe there's a possibility of either adding an antipsychotic on board short term to help them with the sexual functioning, or to switch to something else. So if we were to do that, are there medicines that are less common to have sexual dysfunction? Absolutely. Ziprasidone, quetiapine, and aripiprazole. So Geodon, Seroquel, and Abilify all are way less likely to cause sexual dysfunction. This was a meta-analysis, so it looked at a whole bunch of clinical trials. There were only 4 that were real specific to sexual functioning. And what they found was that the aripiprazole or Abilify was significantly less likely to cause erectile dysfunction or any type of orgasm disorder in males than any of the other antipsychotics, Risperdal, Zyprexa, even Seroquel, Haldol. So it had the lowest risk of developing those. Risperdal, on the other hand, was 3 times more likely to cause erectile dysfunction than some of the other medicines, with the exception of Abilify. So this was compared to Haldol, and it was compared to Zyprexa or olanzapine, and it was almost 4, so 3.9 times more likely. And then it was 4 times more likely to cause different types of orgasm disorders compared to olanzapine. So we definitely saw a pretty significant increase in the dysfunction for the patients who are on Risperdal. So what could we do about that? Recognizing maybe Risperdal is the only thing that works for them. Well, they tried switching. So this was a trial that looked at switching. It was outpatients who had been on Risperdal that for 6 weeks were either continued or they were switched to quetiapine or Seroquel. And they gave them a checklist. So the Arizona Sexual Side Effects Scale. So it's a checklist that looks at a number of different areas of sexual functioning, interest, arousal, enjoyment, as well as orgasm. And they look for changes. What they found was they were about the same at baseline. At week 2, not much of a change. The Seroquel group dropped a little bit. At week 4, they both dropped a little bit, but they really were no different. And by week 6, the Seroquel group had dropped a little bit more, but not enough to be different from Risperdal. So maybe there's something going on with the Seroquel. Maybe 6 weeks isn't quite long enough, but it still looked like there was quite a bit of dysfunction. So switching may not be the best option. So what about adding? Could we add on? So this was a trial that lasted 16 weeks. This was in women. They were on antipsychotics, so more than just Risperdal this time, and they had high prolactin levels. So they were identified to be at risk for sexual dysfunction. So then they did some of those scales, and they said, yes, they definitely have sexual dysfunction. So they were given either a placebo pill or Abilify. So this was added on to their existing medications, and they used that same rating scale. If that scale, so it goes up to 30, so it's 5 items on a 6-point scale. So the maximum score is 30. If you're 15 or lower, it means you have very few sexual side effects. So that's what they used as the threshold. All of these women had sexual dysfunction when they started. Their average score was in the mid-20s, so it was like 24. By the end of the trial, by the end of the 16 weeks, half of the patients in the Abilify group had minimal to no sexual side effects. Only 9% of the patients in the placebo group went from having quite a few to having minimal to no sexual side effects. So possibly having a little addition of Abilify on board may help kind of offset some of those sexual side effects. Last piece, there are a few other things that really could be problematic for patients. More heart arrhythmias, because I wanted to make sure that we tied that in, and temperature dysregulation. So they may not be able to regulate their own body temperature. So if they come in saying, man, I am freezing all the time, I just can't get warm, or I am super hot all the time, I can't seem to cool down. Another reason why we want to make sure that we're collaborating with primary care. So lots and lots of medication side effects, most of which we try to focus on the big ones, but there's quite a few that really could impact a patient's quality of life. And most of them we can't take care of ourselves. So it's be really important to collaborate with our primary care colleagues. With that, I will stop and turn things over.